All right, we'll go ahead and get started. Thank you everyone so much for joining us today for another series of our Ask a Rad, where we're gonna go ahead and discuss varicose veins more than just a cosmetic problem. I'm here joined today by Charlotte Radiology radiologist, Dr. Vittorio Antonacci. He is a board certified radiologist with a subspecialty in interventional radiology, and he will be able to discuss this topic for us, and we will have a live Q&A at the end of the call. So in order to submit any of your questions that you may have, if you look at the bottom of your screen, you will see a Q&A button. So go ahead and you can open that up. Feel free to ask any questions during the duration of this webinar, and we'll go ahead and take a few minutes at the very end to go ahead and get those answered for you. So Dr. Antonacci, he is also a partner at Charlotte Radiology and serves as the medical director for the vein centers here. So thank you so much for joining us, and I'm going to go ahead and kick it off to you, Dr. Antonacci.
Well, thank you for that introduction. Hopefully everyone can hear me. We have a lot of slides today to cover. We'll go through some of the complications that we see from varicose veins, some of the treatment modalities, and hopefully that will answer some of the questions that might come up. But I'd like to welcome everyone who did make it on today. So varicose veins are abnormally enlarged superficial veins. And, you know, when we think about varicose veins, we think of the ones we see bulging under the skin. With ultrasound, obviously, you can see a lot more. So oftentimes with your heavier patients, they may be suffering from venous insufficiency and varicose veins, and you don't see it because of just the adipose tissue. But these are really all defects in the vein walls that lead to bulging, and you have blood flow really going down retro body. You have esophageal varices with scrotal varicocele, and then you can have hemorrhoids as well, which are just prolapsing varicose veins in just different parts of the body. But the lower extremities are just prone to developing varicose veins from just the pressures that are transmitted from being upright in the standing position or from prolonged standing. Oftentimes patients will come in really with no symptoms. So it's important to really look at their legs, and the physical exam is key here. Oftentimes there are subtle things that you can pick up that will lead you to recommending treatment because of just the skin changes that are present, even though the patients aren't particularly complaining about pain. So we do have some patients that come in where the issue is really appearance. Some come in with mild discomfort. And then we have some that come in with long-standing vein disease that's led to venous edema. And what we're finding more and more recently is the venous edema is leading to venolymphedema, where the lymphatics in the past were thought to only account for 20% of the flow from the interstitial fluid in the lower extremities. Now with Starling's law being revised, it's really thought that up to 50% of that interstitial edema is mobilized through the lymphatics. So when you're dealing with lymphedema for long-standing periods of time, and now you're starting to affect the lymphatics, you do wind up getting into more and more complicated situations with your patients. The size of the veins really doesn't indicate how bad the reflux can be. Sometimes you can have smaller reticular veins, and patients can have a lot of symptoms, or they can have a lot more reflux when we look at ultrasound. We talked a little bit about obese patients. Sometimes normal superficial veins will look varicose in some of your very thin patients, and there's variations with temperature and hormonal effects. Usually when we think of varicose veins, it's these truncal varicosities that are coming directly off the saphenous trunks. But you can get reticular varicosities. They're smaller, usually more than 2 millimeters, and you get into the little spider veins. So you have this whole cross-section of appearance. Some patients come in with all three, some patients come in with just spider veins. And so trying to sort through this it is difficult without ultrasound. And the most important thing is trying to triage the patients that do need to be evaluated, and that way we can actually get their venous insufficiency under control. Most of these varicose veins are primary. They just develop over time. Sometimes you do have pelvic tumors, AV fistula after trauma, and DVT that can lead to the varicosities. And we've talked a little bit about the blood pooling in sections of the vein, causing the vein to bulge and swell. Most of the more recent research points to the vein wall as being a problem, and there's some abnormality near the vein cusp with some of the collagenases and elastase, and that leads to the venous insufficiency. About 10 years or so ago now, they revised the terminology. So sometimes when you see our reports, some of the times you see greater or lesser saphenous vein, they all really refer to the same thing. The newer terminology is great and small saphenous, and they've changed the anterolateral and posterolateral tributaries to anterior accessory and posterior accessory. And the reason that's important is that really, when you're getting reports from us, we'll actually have a treatment plan that's describing which veins we're treating. The greater saphenous vein really was always the biggest source of vein insufficiency in the legs, and even back when they were doing surgical stripping, that was really what was the focus. But you do have a pretty complicated saphenofemoral junction. Sometimes you'll see varicoses in the inguinal region and in the groin coming from superficial epigastric. They're not an issue, but sometimes they can take off as a common junction at the top, and you do have to treat them separately. So when you see reports coming from us that indicate we're treating the great saphenous and the anterior accessory saphenous vein, it's usually because of the anatomic variations that are present in that patient that require separate access and treatment. Just another look at the saphenofemoral junction. So years ago, when they did stripping procedures, and they would do high ligation, so they would tie off all of those branches up at the junction. So that really led to problems. You'd have over 50% of the patients coming back with what we call neovascularization, where you'd have varicosities coming off right at the junction, and they were really hard to treat for the surgeons. Well, that was because they were interrupting, in a lot of patients, normal abdominal wall and pelvic drainage. So with EVLT, when we do close the vein with some of the catheter-based techniques, we leave all of these branches open, which leads to more normal flow from the abdominal wall and minimizes some of the issues you used to see with surgery. So why are varicose veins important? Why is venous insufficiency important? Because it's fairly common. We'll see patients in the office as young as 12 or 13 years old and as old as mid-90s. And with increasing age, you'll see more and more patients present. More than half the population, when you scan them at age 50, will have at least moderate vein insufficiency. So there is a significant number, a significant percentage of the population that are dealing with vein insufficiency that may or may not present the way you typically see them. And unlike arterial disease, healthy people get vein disease. It's often, it's actually really, for us, it's more the rule, where we'll get patients that will come in and have very little other health issues, but have severe vein insufficiency even in their 20s and 30s. So just when you do get patients in for their wellness exams, vein disease can be present. So things that can increase the risk of varicoses, obviously they've seen there's a genetic risk where you do have a certain percentage of patients that come in with family history, increasing age, gender, women because of the pressure mechanics related to pregnancies, and also to hormones, which can affect the elasticity of the vein walls. With obesity, you get elevated right heart pressures that get transmitted to the veins, so that can cause them to weaken more quickly and sooner. So you'll see patients with obesity that do have a higher incidence of varicose veins. We talked a little bit about pregnancy. Prolonged sitting and prolonged standing are both bad for veins. So prolonged standing, it's just the gravity effect, and prolonged sitting, you're actually mechanically compressing the common femoral junction. Other things like trauma and phlebitis. So those can also lead to earlier varicosities, or sometimes unusual presentations when patients have had trauma in this part of the leg before. You can get isolated varicosities there. So how do patients present? They present usually with pain, heaviness, aching, tenderness along the vein. Those are pretty common symptoms. Sometimes itching and pruritus, or burning can sometimes be a little bit something that's less common. For us, some of the most important things are things that are overlooked in the physical exam. So night cramping, we get patients not infrequently that come in with night cramping once, twice, 3 times a week, sometimes nightly for years. And they've failed medical treatment, they're miserable, it interferes with their sleep. And we treat their venous insufficiency, and it's not infrequent that 2 weeks after their endovenous laser treatments, they come back in and their cramps are gone. So for us, when we get patients with night cramps, that's a very important symptom for us, and it's something that you can easily screen in the office. And if you don't have any other treatments that are successful, and you can try compression stocking, see if that does help, and if it does, that's a good subgroup of patients to get into us, because once we treat their venous insufficiency, that will go away. 80% of our patients that have cramping will get rid of their cramping symptoms within 2 weeks of their procedures. The other thing is restless legs. Probably half of the patients with restless legs, we can either decrease the medications they're on to control that, or we can actually improve their symptoms to the point where it's not an issue. Oftentimes they'll describe this jerkiness at night before they go to bed. That commonly we can treat and alleviate with the vein treatments. But less commonly, so exercise intolerance, and sometimes that could be subtle. When I had my vein treatments done, I found that I had finished my exercise routine of 3 or 4 miles that I was running at the time, and I realized my legs weren't tired. I was stopping my exercise because I thought I'd gotten a good workout, and actually what it was the lactic acid building up from the venous pooling and making me feel like I had exercised more than I did. So after my treatments, I actually improved my exercise tolerance. As we get into things like edema and skin changes, that's where we start getting into the more significant complications and why varicose veins are important. And we'll have plenty of examples here that we'll go through a little bit more quickly, and we can come back and ask some questions at the end. But thrombophlebitis, I'm sure most people here in the office have seen. It's basically thrombosis causing inflammation. The important thing, the reason why all these patients do get their deep vein ultrasounds as well, is because you can't have associated DVT with these patients, or sometimes you can get superficial thrombophlebitis that can extend up and progress into DVT. So the ultrasound screening is important, but oftentimes realize that when you get ultrasound reports from different hospitals or different clinics around town, they may not comment on the superficial veins at all. So that's just something for you to realize when you're going through those reports. The treatment, low-dose aspirin, analgesia, no real need for antibiotics, warm compresses. To be a more important role than we previously thought. We start getting into patients that will come in. When you have asymmetric pelvis, so we'll treat patients, we'll screen patients depending on their histories, depending on their response to some of the vein treatments. You may get reports from our office saying that we'd like to get a CT venogram to further evaluate for pelvic obstruction. So edema, patterns of edema are important. Skin pigmentation, once you get long-standing edema, you get the blood cells hanging around and they rupture, they start depositing hemosiderin, and you start getting different pigmentation either in a vein that has thrombosed or even in the skin. And that leads to, and that pressure leads to, inflammation over time. And whenever you have that poorly nourished, oxygenated skin, you're just going to start getting inflammation leading to eventual scarring. So venous dermatitis, varicose eczema, that you'll see. And here you can see there's also associated lipodermatosclerosis. Oftentimes you get patients where it's confusing. They'll have these darker patches that are already scarred, and you may have some areas that are more red and inflamed in the periphery, and those are, and that's the skin at risk. Sometimes it can be exudative. Lipodermatosclerosis, when you do get that, we get patients that have had that for years. It doesn't happen overnight usually. And the skin really starts getting tight, and brown, those are patients that really need to get in for evaluation, because lipodermatosclerosis is really the last step before you get to ulceration. These patients have already permanently irreversible damaged skin. We'll get patients that'll have these patches, and they'll ask us, well, will this improve with treatments? Unfortunately, once you get to the scarring stage, all you can do is keep things from progressing and hopefully not getting to this point where, the next step after the lipodermatosclerosis is you get a little bump or injury that doesn't heal, and then you're trying to heal an ulcer. So ulcers are pretty miserable for our patients, and it actually affects a good percentage of the general population. When you look at patients with ulcerations, now you're having patients getting wraps at some of the wound centers, and they're dealing with that. The ulcers may or may not heal, or they will heal, but then recur. So whenever you start getting to that lipodermatosclerosis or early ulceration type point in the patient's, for the patient, that's time when that's the time we need to get them in to have us evaluate them. So the medical management, debriding, different dressings, different lotions, different ointments that they're now applying, but basically, it does work. 83% of ulcers will heal within 24 weeks. The biggest problem with ulcerations is that 2/3 of them, 70%, will recur within a year if you don't treat the underlying cause. So when we look at what happens when you do treat patients that present with these ulcers and have superficial insufficiency, their recurrence rate goes down to about 25% at 3 years. So really, really significant improvement in their quality of life and in their overall medical course, in their mobility. We'll see patients that come in that, significantly affected by these ulcerations. So if you can get to them at that lipodermatosclerosis stage, you're just so much better off. So when I used to give these talks early on, I'd get hecklers and they'd say, well, varicose veins really don't mean a whole lot. And isn't it because, or aren't people doing procedures because they're daughter-in-law who had white carpets and they bumped their varicose veins on, the top faucet or something getting out. And next thing you know, they wind up in the ER with someone tying, a purse string suture around the area that bled. So we see hemorrhage not infrequently. And, there are some trauma audits that show that some patients, hemorrhage in their sleep and don't wake up. So can varicose veins lead to significant enough hemorrhage that patients expire? There are plenty of articles out there that describe that. Some of the less common complications you'll see, atrophy blanche is just a different type of scarring where it's a little bit less pigmented. It's actually it's actually hypopigmented, and sometimes it'll present within areas of inflammation. Just to give you the range of what you might see. So when we're treating varicose veins venous reflux, conservative therapy is always the first attempted treatment. So we tell our patients to elevate their legs, avoid prolonged sitting, avoid prolonged standing, not crossing their legs, weight reduction, and compression stocking. Now, compression stocking has gotten a little bit interesting over the last 10, 12, 15 years. Some of the insurance companies use this as a barrier to entry for patients for their treatments. So even Medicare this year switched to a 3-month conservative therapy trial for patients before they're able to receive treatment. So we get patients that finally make it in, are very happy to have their diagnosis and are eager to proceed, and then we have to wait 3 months to see if they respond to compression stocking. And the thing with compression stocking therapy is it doesn't matter if the patients improve or not. They'll usually all be approved for procedures. It's just this hurdle they have to get through. So we have prescription pads in our office. We can get these to your offices. There are some that the individual stocking distribution centers will have. Some of the retail, like Compression Works, has their own prescription pad. But as long as we get our patients into this low dose range, this 20 to 30 millimeter strength range, that's sufficient for insurance purposes. And you can do that in the office before you even schedule them for a consultation. So that way we get ahead of the game, and they're only waiting maybe 4 to 6 weeks before we complete their therapy, as opposed to waiting to get into our office, having the prescriptions written. And this low dose, while the literature supports using more moderate strength and higher strength, depending on the severity of the disease, I found that 70% of my patients won't tolerate the 30 to 40 millimeter strength. So if you just check off ready to wear or the ready to wear low strength thigh high, it has to be thigh high, because knee high really isn't considered a sufficient trial for Medicare. So the thigh high, low strength, if you get that to your patients, that'll get them really ahead of the game when they come in for consultation, whether it's at our center or at any other vein center. So management of vein disease has changed. When I was in medical school, I used to hold up legs while the surgeons would pull out greater saphenous veins. It was really lovely. Patients would be in bed overnight and at the hospital, and at home 2 weeks in bed. They would have these different devices. They'd pull veins through. Sometimes the little nerves would come with it, and they get a whole lot of bruising and whatnot. Things changed about 2000 with the Endovenous Techniques, where we go in with either radiofrequency, which is electrical cautery probe, or a laser, and we just run that into the vein, which actually is pretty easy. It's sort of like getting a PICC line in or an IV. We check under ultrasound the level of where the actual fiber is, and then after local anesthetic through that area, we go ahead and pull this catheter back and close that vein. Injection sclerotherapy is sort of the cleanup part of the procedure. When we close those big trunks, you don't get all of those spider veins and reticular veins we talked about go away. Those you do have to inject, and usually we're injecting Sotradecol. And there's two types of injections. Here we're seeing sort of the dermatologic, more cosmetic injections, but when we look at sort of at the end of the presentation, I'll show you where, as interventional radiologists, we use ultrasound to actually do a little bit more detailed, comprehensive sclerotherapy, where we get those perforating branches and communicating branches. Ambulatory phlebectomy, still occasionally you'll see us recommend in some patients when they do have some of these big ropey veins at the surface. There still can be a little local surgery that may be helpful in removing those, so that way they get less trapped blood from the sclerotherapy and just heal faster. Sometimes you'll hear about cutaneous lasers. Those are really more for those little 1 to 2 millimeter spider veins. So why is interventional radiology involved in all of this? Well, because of the technology, the ultrasound technology, and using and knowing how to use ultrasound to map out different vein patterns. Is it the greater saphenous vein? Is it part of the saphenous vein? Is there reflux into the posterior accessory saphenous vein? So that's what we do when the patients come in. We map out the highest point of reflux to the lowest point. We look at incompetent tributaries. And we use the ultrasound to follow up. Has the patient been successfully treated? Is there reintervention needed? A good example of what the greater saphenous vein looks like dilated on ultrasound prior to treatment, following treatment, and then a year out where the body is almost completely resorbed it. So we look for new sources of trunk reflux. Oftentimes treating varicose veins is like pruning a tree. We'll treat the greater saphenous vein and the lesser saphenous vein. Some of the accessory saphenous veins may be borderline, but as you treat some of the bigger trunks, you'll realize those need to be treated as well. We talked a little bit about the ultrasound-guided sclerotherapy. Here is what that looks like. We put a little needle in the vein, inject it, and because we mix this into a foam suspension with carbon dioxide, you'll actually can see the sclerosant traveling into perforating veins, and we can get a really comprehensive treatment of the residual trunks. I think that's what really sets us apart from a lot of the centers. Oftentimes the surgical approach is that you treat the big trunk veins and they'll leave a lot of those smaller veins behind, which then we have, when patients recur, we wind up going back and treating. And probably 50% of the patients we see from other centers for recurrences, they haven't gotten all the trunk veins. So that's where interventional radiology, ultrasound, all of those, paths came together, and why you'll see a lot of interventional radiologists treating. Just history-wise, I was the first person in North Carolina doing endovenous laser treatment back in 2001, one of the first 20 centers in the country. So we have a pretty long history. And I think that really just that experience with all our providers really is what gets your patients really excellent treatments through either a center at South Park or Lake Norman. So in conclusion, varicose veins can be a sign of serious underlying pathology. Understanding the anatomy and variants is critical in treating. Ultrasound and just being the gold standard diagnostic modality for understanding individual anatomy and guiding individual treatment patterns. I have a couple of pictures here just to finish up of our centers. So we're over in South Park, and then up here at Lake Norman. This is just what some of our ads have looked like that you may come across in some of the different magazines in town. Our team, so this is our original team with our 5 physicians. We have 2 other physicians now that are up at Lake Norman working, and this was our core team of technologists, Terry, our technologist, Pam Harrell, a nurse, and coordinators you may wind up speaking to on the phone. We have really grown that to an excellent, just expanded team. We have 3 or 4 nurses at South Park and 3 up at Lake Norman, all just really that are part of the team approach to getting our patients treated. So this is our South Park office, our coordinator's office, our physician's office, what our treatment rooms look like. Pam Harrell, one of our lead nurses here, helping for an exam, and Alexis in another room. We have 3 treatment rooms at South Park. Some of the brochures that are available through marketing to give to your patients that help explain some of what we've talked about today, and just to give them an overview. And finally, just the appointments or for more information, the number to reach us at. And I think that brings us to the end here.
Thank you so much, Dr. Antonacci, for that insightful presentation. I know we're getting close to the top of the hour, so we can go ahead and take a question or 2 if anyone has it. But again, this is being recorded, so we will also post this on our referring physicians page on the Charlotte Radiology website. So you'll be able to go back and look at this presentation at any point in time once it's uploaded there by the end of the week. So if you have any questions, please feel free to put them in the Q&A button, which should be located at the bottom of your screen. If you would like to verbally ask a question, you are on mute, so you will need to raise your hand. Once I see that you have your hand raised, I will unmute you, so that way you can go ahead and ask your question to Dr. Antonacci. And if any questions, I was going to say, if any questions come to mind, later on after the presentation, feel free to email us. Our email inbox is called information@charlotteradiology.com, and I will make sure to get those questions over to Dr. Antonacci so that he can get them addressed.
Well, I did want to just, while people are typing in questions or thinking about their questions, just some of the things we commonly get are, how to get patients into the office. So, the online portal, the office number, things like, what do I need to do for my patients? If you can get them in those compression stockings, even the 20 to 30 millimeter strength, that really helps just speed up the whole process for the patients, because if they're waiting 2 or 3 weeks to get in to see us, and they've already purchased their stockings, it's just that much less they'll often have to wait for their procedures. And that way you can also get some feedback on how well they're doing with those stockings before even they see us. They may call you back and say, my cramping has really gotten better. So those are common things. Common symptoms that are important. We talked about the cramping. Another sign that is really important that we'll often see is hair loss. So if you get men that have, hair loss in their lower legs, when you're walking on the golf course sometimes at these events, I can, almost, you can see people from 30 yards away that would benefit from vein treatments, because that hair loss starts to happen from that congestion that affects the oxygenation of the hair follicles. And they'll start to thin and lose hair. First it's patchy and then it's more uniform. But those are the type of patients where just looking at them, you can almost right there, write a referral for venous insufficiency evaluation. And again, whether it's at our center or somewhere else, because if you're waiting for the varicose veins or the skin changes to worsen, you're just that further behind where you could be.
Great, thank you, Dr. Antonacci. So I am not seeing any questions come in, which means that you must have done an amazing job at describing the different procedures that we have here at Charlotte Radiology. But as Dr. Antonacci also mentioned, we do have some marketing materials that are available for you and your patients. So feel free to reach out to us at information@charlotteradiology.com, and we will make sure those are delivered to your practice. So if there are no more questions for today, we'll go ahead and wrap it up since it's a little bit after the top of the hour. Thank you again, Dr. Antonacci, for sharing your expertise on this subject. We really appreciate it.
Thank you.
Yes, thank you, everyone. Have a great afternoon.